So welcome everybody. Hopefully everybody is excited as I am. I mean, it's the wonderful Sunday. I mean, in Manchester, it's not so wonderful as probably somewhere else, but hopefully you enjoy throughout the day. I'm just going to start with a small presentation for about 10 minutes or so. Can just somebody confirm for me that it's on at the moment?
Yes.
Wonderful. So it's about suturing, and I'll go through key points why we think you need to know that, where it might be useful. You don't necessarily have to be in oral surgery to do suturing, but it's useful skill for dentists, and you as you are one of those unique professions who registered with GDC straight away, and you are dental surgeons, so you can perform surgeries from day one when you qualify. And that's a quick key points that I wanted to raise in this presentation. Why suturing, and then a little bit about thread, needle, and general principles. And then I'll show you a video on the pad that you received as well of the technique as close and as clear as possible as we could get. And then we're going to go into practice rooms. Now, suturing is an essential skill to perform surgery. It might be required due to trauma, especially for younger kids, and for, well, I mean, there could be adults as well, and some alcohol-related trauma. Sutures would allow healing by primary closure. So I would invite you to read about inflammation and healing process. For example, if it's a planned surgery, you would want to close everything as it was before. That would be primary closure. Sometimes the secondary closure is only achievable. For example, with extraction, the healing process is achieved really by a secondary healing. So you don't really close it, but you can use a suture to help you, like a cross mattress suture, for example, for a socket. And the main message throughout the presentation is that you can plan ahead. There are so many types of sutures, and we only cover a few, and it's already 5, but there are plenty more by authors, etc. But the main thing today is that keep things simple in your practice and plan ahead. Now, there are several suture types, and I'm going to briefly mention that the main ones are resorbable and non-resorbable. In dentistry, you would use normally absorbable most of the time because that dissolves really well in the mouth and saliva. They are vicryl and vicryl repeat. They will become insufficient in about 7 to 10 days, but inside the tissue, they resorb about 30 to 50 days actually. So this is small disadvantage that they probably cause a little bit of a local inflammation reaction. And there's some scientific research actually that braided resorbable suture accumulates plaque, but that's interesting scientific fact. I don't think so it has a significant clinical effect. There's also monofilaments, and I'll show you what means by braided and monofilament. Some of them are redundant, really. We don't use them anymore. And non-resorbable sutures are braided and non-filament. Basically, monofilament is probably mostly used. We have braided as well, which such as silk. And monofilament is Ethlon or Prolene, and they're really good for microsuturing. You would come across a couple of papers and Royal College of Surgeons guideline that for apicectomy you would prefer non-resorbable monofilament suture because there is some evidence that it's causes less infection, which makes sense because it's nice and clean suture that doesn't accumulate plaque and doesn't collect any bacteria on it as well. But just to look into scan electron microscopy for sutures. Now, on the left-hand side, you have a resorbable, and on the right-hand side, non-resorbable. And you can see that on the left-hand side, B and C are vicryl and vicryl repeat. So those are, I mean, those good sutures that dissolve themselves, so you don't need to actually have a follow-up appointment with the patient. In case of trauma, it's perfect. In case of some surgeries like simple extraction is perfect, but maybe complex surgeries such as bone augmentation or implant placement or apicectomy, you might want to consider, especially if you have liberty in practice. or to move on to right-hand side, monofilament, such as C, E, and F. Those are ethylene and proline. They're nice and smooth, and they really hold flap really well. So that would be probably recommended for some more infection-sensitive procedure. Some of it is personal preference. Some of it is what you have in stock and how things done logistically. But that's how they look under a microscope. So you see the difference between braided and monofilament. There's quite clear difference. Now talking about needles. Needles are various form, and actually in the kit that you have, the needle that you have is a half a circle. You can see it's quite large, probably something different to what you have in practice. Normally you would be working in dentistry with 3/8. It's sort of 3/8 of a circle, because in the mouth, closed space, there's your fingers, your instrument, patient's tongue. You don't really have much liberty with half a circle go around the tissues you want to suture. But for the practice on the pad, it's probably better to have half a circle so you can clearly see the needle and clearly see all undulations that have to be within the needle. And on the right-hand side, you can see that they're different shapes as well. The one that we use is reverse cutting, which is second in dentistry. And this is purely because it's mucosa, and mucosa can stretch. It can be sometimes fragile. So you won't have the cut on the opposite side. That's why it's reverse cutting, which also helps to go through the skin. Now, if you have just a pointy, a tapered needle, that will be not really good for mouth because the mucosa wouldn't go through easily. With reverse cutting, it just cuts it underneath a little bit, enough for needle to pass through easily. And that's basically the main difference. So in dentistry, you would use Vicryl or Vicryl repeat as resorbable, and non-resorbable, you sometimes use silk on a rare occasion, and mostly proline and nylon. And 3/8 circle, it would be your preference for that. Now, some general principles in terms of instruments. In your kit, you will have a needle holder, you will have scissors, and you will have forceps. Now, forceps are good for the pad, but in practice, you will have teeth forceps, because they cause less trauma to the mucosa when you hold it or handle it with the forceps. And just pay attention at the position of the hand. This is perfect way of handling instrument. Obviously, if you left-handed, then it's the other way around. But the index finger is always supports the instrument. There is no difference holding scissors compared to needle holder. You always have an index finger holding your instrument from the top to make sure that you position it well and it's controlled position at all time. And there's some general principles about needle holding. So you hold it at 2/3 of the needle, closer to the thread, okay? That gives you enough space to move it around. And because needles are circular, they're not straight, you don't actually put forward or backwards forces when you pierce the mucosa. You actually do the round movements with your wrist. That's why the needle is in a circle. So that's the only circular movements you do. And grabbing it by 2/3 of the needle gives you plenty of room. It's perpendicular to the needle holder. And again, once you get more advanced in suturing, you can bend the rules. You can't entirely break them, but you can bend the rules as you see fit future in the practice. And make sure that your needle holder is locked. Other principles is that when you pierce the mucosa, you really need to be 90 degrees to the mucosa. And going through about 5 millimeters from the end of the wound, perpendicular to the surface, and it's a circular movement with your wrist. There is no pushing forward or backwards, it's just really circular movements, copying basically the shape of your needle, if you wish. and make sure that the depth is equal on both sides of the wound as well. So that's the bottom picture here as well. And the way it comes out as well, perpendicular. And when you're going to tie it, I'm going to show you how to tie that. You're really looking into, the most important is to get your surgical knot correct, which is the first knot, or shall I say double twist. It should come up and you should see it really laid out nicely, like here in the picture. Because if it's locked or not in position, not positioned well, it might render your suture insufficient, and you might have to either redo it or adjust it somehow. And now talking of the technique, so this is the first suture that a must know, and basically you can do most things with a simple interrupted. So what you can see in picture here is a simple interrupted suture for implants on the left-hand side, and generally for a flap on the right-hand side. And on the left-hand side, you can see that you start piercing the papilla. You can use as margins of your wound. It could be papilla, it could be a clean relieving incision on your flap, could be anything really, as long as it's suitable. And simple interrupted suture can really sort most problems. And you can see for implant dentistry, it's also possible to have simple interrupted. There's no need to make things too complex. And then you tie it well and cut about 5 millimeters. So the thread cuts about 5 millimeters as well. And it's all done. And on the right-hand side picture, you can see that you can secure the socket, and then also your relieving incision, the number 1 and number 4 knots, secure the relieving incision as well. So you can do most things with simple interrupted, really. And I must say that a lot of other sutures are based on the absolutely same principles as simple interrupted. So once you get your simple interrupted really good, you won't struggle with anything else. And that's the clinical picture. That's the maxillary tuberosity, which was identified. The cut was made, tuberosity was removed. And in picture D, you can see 3 lovely simple interrupted sutures positioned, that's securing things really well. And slightly more complex suture is continuous. Continuous suture, basically, you place a simple interrupted suture at the one end of the wound, and then you cross it over and just basically doing some sewing, really. And then you finish it off with the loop, which I'll show you in the video so it all makes sense to you. And this is A and B. And C and D picture is continuous suture, but locked. So you create a lock. You basically put the needle through the loop before you carry out the next suture. And I'll show you that in the video as well. And we're going to finish off with the mattress sutures, such as this. So on picture A, you can see a, wait, just going to move this thing if I can. Picture A at the top, you can see a horizontal mattress suture, a classic horizontal mattress suture. It's the same basically principle as simple interrupted, but with no interruption. You just continue on the other side and tie it up. It can be used for a socket as well on picture B. And at the bottom, picture A and B, this is a cross mattress suture. And cross mattress suture really good for socket. It can be 2 types, can be inverted as well. So basically, if the cross, which is created, is inside the socket, or basically at the top of the socket. So this is slightly different to what the video I'm going to show you, just so you know, and then you can practice and it all makes sense. So we have plenty of time for practice room, and I think I'm going to just finish off with presentation at the moment, and start the video. So I just thought this lovely morning that maybe we should have a simple interrupted video first, and then we'll break into our practice rooms for about 20 minutes to practice and then get back. So let me start the video. Right, so that's the familiar to you pad. And just holding instruments, this is how you hold a needle holder and you can see the needle is secured safely in a needle holder, so nobody can basically injure themselves. It's common sense, but you know how many times we sort of have needle stick injuries, so we'd rather prevent that. That's the forceps that you have. And the scissors. So to start off, you position it as 2/3 towards the thread. And then in the other hand, you hold the tweezers and you basically hold the tissue and pierce the mucosa at 90 degrees, 5 millimeters away from the margin. You can help with your forceps to grab the needle again, but you can just do the same with the needle holder. Depends how you feel comfortable. And then you do the same thing on the other side of the wound, aiming for the same depth. In dentistry, sometimes it's the whole depth, because sometimes you just have a proper flap. In some occasions, you have a wound like that. And basically 5 millimeters from the edge again. And this is to ensure that when you reapproximate the wound, it reapproximates well and almost identical to what it was before. Then put in the middle of the wound, put your surgical thread twice. And then this time you can really look into how it's coming along. You can play around with it and visualize that surgical knot that should come across, and then reposition the wound and assess, is that an okay positioning? Do I need to redo that, or is it good enough? And if it's good enough, you can lock it in place and do, I basically do 2-1-1. So the first knot is twice as surgical knot, and the rest I do once, but some people do 2-1-2. Okay, and then you cut the remaining thread about 5 millimeters as well. Is okay, just like that. And once you've done with the suture, you can use your tweezers to check that it's sufficient, it's well positioned, and you can also place the knot on the correct side. Normally would be buckle. Just at the different angle, really, you can see the needle comes almost 90 degrees because it's half a circle needle, so it's a bit difficult to get it. But try as 90 degrees as possible, perpendicular to the mucosa. And when you're going to go to the other side, similar depth, you can use the needle as I use it on the video, just to make sure that I get my perspectives right. So I put the exit of the needle is almost exactly same place where I inserted needle on the other side. Place the needle holder in the middle of the wound, cuddle it twice. That's your surgical knot, and then bring the threads opposite direction, and you can see the surgical knot coming up nicely here, and you can leave it like that. Again, needle holder in the middle of the wound, this time cuddle once, and bring the threads on opposite direction, and the same again. So it's 2-1-1. And once you're happy with that, you can cut the thread about 5 millimeters. And again, sort of play a little bit with the knot just to make sure that it's sufficient, and place it on the correct side. Here we go. So I'm just going to stop sharing. I think we are ready to go into practice room and practice simple interrupted. Let's say, so how good are we with time? Let's say 15 minutes. So let's have a look at the continuous simple and continuous locked. And I'll be commenting as well. So pick a longest wound. you have on your pad, and start with simple interrupted. Easy as that. So here we go. Your simple interrupted now comes handy already. Going through one side of the wound, reposition it, get your perspective, and put the other side. Same distance, same depth, and all is about 5 millimeter. And again, it depends on the clinical situation, but you don't want to be too short or have a massive bite. Then again, in the middle of the wound, cuddle twice. Take the tail and get your surgical knot aligned. Just like that. Once it's there, cuddle it once. And once more. And again, some people do 2-1-1 or 2-2-1, but that's the way I do this. So, and this time you cut only the tail. So you don't cut the main thread. You only cut the tail, and you just continue with stitching pretty much. So that's more of a sewing you do. You just go on the same side as you started. So imagine it's buccal side, and you're going through, I don't know, lingual side. And you just carry on going, and the video will speed up in a second. And I would suggest you to go through the whole length of the wound. And every time you do it, you reapproximate the wound, just seeing how it comes up. And if you're not happy with something, you always can adjust it a little bit with your subsequent knot. The main thing is that your insertion and exit are parallel to each other. Then you're not going to distort the margins, because you almost need to reapproximate them where they used to be, where they belong to. And this is the good type of wound on the pad here, because it's quite, how shall I say it? It's not a simple line. So it's sort of like an S shape, but you can pick slightly above that is a simple line. So now let's finish the continuous simple. You put your last stitch, and you can see I put it for both margins at the same time because I feel comfortable with that. And this loop you use as your tail. So this last loop you leave loose because that's going to be your tail. And then you start finishing up. Twice cuddle, use the loop as the tail, and reapproximate it. Again, once, and reapproximate it, and another one. Prophylactic, I call it. And basically you cut 3 threads now, because you ended up with the loop and with the original thread that belonged to needle. You cut it, you check it, reapproximate, it comes up nicely. There are a few things that can be improved, but we can talk about that in practice room. Now the same one, but locking. Let's start with this wound. You basically put a simple interrupted again, and I go through both sides now. Surgical knot, once again, and once again. And you can see that the tail always ends up on opposite sides to where it started. And then you cut 5 millimeters, but only the tail. So you leave the big thread intact, and you just carry out. So continuous locked has specificity about that. You just start going through the wound as you would do with continuous simple. But then your assistant usually will help you to keep the thread under the tension. So the loop that is created, and I'm talking about this loop, you use it to put your needle through it. And that's how you lock it. And that's pretty much same continuous, but you just use the loop to lock it in place. And then you basically, it's going to speed up in a second, and then you carry out the rest until the wound is finished or complete. But basically, main thing here, we don't have luxury of an assistant, so nobody can keep the thread under the tension because it's quite important for this suture. So don't expect it's going to come up perfect, but you should be fine to readjusting it every now and then. Then again, I put the needle, it's a bit fiddly, put the needle through the loop, and it basically comes up like that. And ideally, the lock is at the bottom of the wound, but you can readjust it as well. And you just carry on. These sutures are normally used for big lacerations where the edges are created by the blade. So I wouldn't say that this is good for trauma cases, but it's good for bimaxillary osteotomy. Now again, you use this loop to finish off. Again, instead of putting the needle through the loop, this time you use this loop as a tail for your surgical knot, and then at that point you can readjust things, and again you cut it through. So it's a little bit on a complex side, but we can go through in practical room. Right, so I'm stop sharing, and I think it's time to disengage for 20 minutes, shall we say. Right, so I just welcome you to 3 types of mattress suture: horizontal, cross mattress, and a vertical mattress. Let me just, is the video broadcasting well?
Yeah.
So horizontal mattress, you start with a simple interrupt again. And you by now a specialist, so I go through both wounds at the same time, actually, through both edges. Yeah, bear in mind those knots. I left it there on purpose and ended up cutting it. But anyway, so with a simple interrupt, it is slightly different. But now once you placed through the wound once, you just go back. You take about 5 millimeters on the same edge of the wound, and you just go backwards now. And that's the horizontal mattress suture at a glance. So it's actually ends up like that. Oh, there was a close call. Fine. So, and the beauty of that suture is that nothing really goes on top of the wound, because you know your suture crossed the wound before, but with horizontal mattress, you're reopposing wound edges without actually going through the wound, or on top of the wound, sorry. And then you don't put too much tension, but enough to close it up, and just a regular surgical knot, and you close it. And that's the horizontal mattress. Checking as well that's all nice and sufficient. Happy with that. Fine. Cross mattress. Now there are 2 types of cross mattress. You can do it either way, but the way I do it is that this is a socket of the tooth. You extracted the tooth, and you just need to make it a little bit more tight, because the gums just got a bit, loose. You go from one side of the socket, and then inside the wound, you cross it, and then end up on the opposite side. And you always have to bear in mind, you try to picture the cross that will end up inside the socket. Some people place the cross mattress suture where the cross is actually over the socket. Both are fine, I guess, depends on the clinical situation or on your preference. And then as a horizontal mattress, you just go backwards again, similar way. The only difference is that you are crossing your suture inside the socket. Again, similar to horizontal mattress here. but then you cross again and end up on the other side. And the aim for this suture actually not to completely close the wound. In certain circumstances maybe, but it's just sort of basically to reinforce gums if you place this suture across the socket. But for silicone pad, you obviously can sort of, close it, and because it's quite soft. And again, in the middle of in between of two threads, locking it, surgical knot. And I mean, again, in here, I closed it because obviously silicone is quite soft, but if you would be doing it with a socket, the bone actually would prevent you from complete closure, which is good because after extraction, you would have a secondary, under secondary tension, really, the healing. And cut about 5 millimeters again. Perfect. Well, now let's move to a more fancy one, vertical mattress. So vertical mattress is good for papilla. So that's why I picked this particular lesion here. And you go as a simple interrupted again through the top. Let's imagine those are papillas. You can do it on any actually lesion. It's good for palatal flap. So you placed your simple interrupted, and then you place another simple interrupted just underneath your first one. So you go slightly behind it and slightly underneath it. Okay, so I'm just trying to project where my needle will go. It will go about here, and I go underneath, and I go all the way behind. So it's pretty much I place one suture, and then underneath it, another suture with no interruption. And that's what makes it vertical. So you see there is no horizontal plane here. It's all vertical, and it's mattress because it doesn't cross the wound. It's basically all underneath. So that's quite good to preserve the papilla if you don't want to, put a tension on top of the papilla with your suture. And then you just make the knot as you usually would. I do first surgical knot, reapproximation, no need for massive tension. I locked it. As you can see, I just locked it just to keep it in contact. Another knot, and another knot. Just gonna show you the way I locked it again. So I'm just gonna do it once more. So you go between two threads, do it twice, surgical knot. And to lock it in place, I just move it slightly across under the tension, and that should tighten up my surgical knot a little bit. And then the second one and the third one, 2, 1, 1. Again, you might want to do 2, 1, 2, personal preference, I'd say, and 5 millimeters cut. Here we go. So there's a little thank you message coming around, but we're not finished yet. And you just can sort of have a look around, measure things, play with your sutures, just make sure it's all sufficient. Right. So why wouldn't we go back to practicing room and practice mattress sutures?
Says, how do we make a tighter knot? I keep making the same mistake but don't know what it is. My knots look okay, but they are not as tightly to the skin as they should be.
Yes, so to make a tight knot, things to get first is a good surgical knot, that the thread goes around another thread in a nice manner, it's not locked. And then to give a tension, good tension, and then lock it up. Basically bring it on the opposite side, if that's what comes to the point. So actually, maybe do we have a lecture if I can show quickly maybe? on a simple interrupted. So if I just spot this slide here, I'm just going to do it quickly. So you place your interrupted suture, simple interrupted. I mean, I'm going to do simple interrupted on this occasion. Just let me say just like that, okay? And then you're ready to make your first surgical knot. I put always in the middle of the wound, and I cuddle twice, and I bring the tail to the opposite side, and you can see the surgical knot comes up really, really nicely. So that's when I can put a little bit of tension. And to be honest, in majority cases, the tension stays like that. So you see, it's not going loose. And I keep that fairly loose, because if I'm going to go put tension on this thread here, it's going to loosen it up a little bit. So you always have a little, your hands are on suspension. You don't put any unnecessary pressure on the knot. But if you have a wisdom tooth surgery and there's, you know, masseter and everything, you put the bit of pressure here, and then you cross it opposite side just like that. And once you cross it just like that, it locks it in place. So now you have a bit of time to put your next knot and another one. Okay? And then you cut and all the rest. Does that make sense?
In which clinical situation would you use each of the different techniques?
That's a wonderful question. The downside of that question is quite a big scope. So I try to sort of make sort of long story short by saying that a lot of the clinical situation can be sorted with simple interrupted. For palatal flap, where there is keratinized mucosa, for ectopic canine, for example, to go through the papilla from buccal to palatal aspect to close the palatal flap, you can use Mattress vertical. Is really good. You go for the papilla and you preserve papilla. The rest can be sorted with simple interrupted, and for the socket preservation, or to sort of reinforce gums around the socket after the extraction, for example, you can try cross mattress suture. The cross will go either over the socket or inside the socket, and you can even put the Surgicel or whenever the preservation you want to do, and that will keep gums reinforced around the socket and also keep the inside bit, either a blood clot or Surgicel secure inside the socket. Horizontal you can use for implant surgery. Horizontal is good, sometimes for periodontal surgery as well. But to an extent, it's sort of, you know, it's all down to personal preference, experience as well, because some sutures more technique sensitive than others, and also your clinical scenario you have. So there is no like a definitive answer to that question, and the answer, it's rather large. It could be the whole separate lecture on the flap design and the suturing of the flap or wound. And as I said, little example to my group, that I had a patient referred urgently because dentist basically was sorting out the crown prep with the disc and cut the floor of the mouth by accident, and then they send the patient, and I was like, oh my goodness, what I'm going to see. But what I saw is actually that general dental practitioner already placed 2 or 3 simple interrupted suture in the floor of the mouth, closing the wound perfectly well with Prolene. So I mean, suturing can be, I mean, as a dental surgeon qualifying, you could potentially need to place a suture in different circumstances. Depends on your work and the way you work. So it's good skill to know, and cross mattress is like paramount.